So I'm going to be the moderator of this boot camp. We have some fantastic faculty speakers in the lineup for today. And again, I'm going to cover housekeeping. We are going to field all questions at the end. So I'll come back up and moderate, and we'll be able to give all of the speakers their questions at the end of the talk. So again, welcome to particularly the 2024 IBD Bootcamp. This bootcamp will really provide you updates about IBD, including all of the novel therapies that have come out, as well as just a comprehensive overview from pathophys of IBD all the way through some positioning tips. So this 2-hour session again will be led with some fabulous faculty from all across the country and top IBD centers of excellence. So the initiative, and obviously our audience is all of you guys, GI and hepatology, APPs, and those of you who have an interest in IBD. So here is an overview, including our speakers and the 6 breakout topics. And again, we'll spend the last 20 or so minutes doing Q&A. So just remember those questions. We will happily get to as many questions as we can. Here's disclosures for the planning committee and myself, and each of the faculty will come up and introduce themselves and go through their disclosures. And just following again for disclosures, everyone will list their disclosures. This has all the disclosures and disclaimers related to medical education and the GHAPP planners. And then here's our educational objectives. So upon completion of this activity, participants will be able to better describe the MOA safety and efficacy of our therapies across the IBD platform, including some of the more newer emerging therapies in IBD. Again, also including the newest emerging therapies in ulcerative colitis. We will also really focus on some guideline-based recommendations for these therapies, and then really summarizing the impact that bowel urgency has in our IBD patients, particularly our ulcerative colitis patients, and how we can all use this as not only a discussion point with our patients, but a way to further help us guide and hit our goals of IBD management. So here is the accreditation. There's also QR codes at each of your seats. Just make sure to scan that QR code so that you can claim your credit. But as you can see here, this has CME approval for 2.25 CME credits. So here again is those tips on claiming credit. Again, each of you has a QR code on your seat, and it will walk you through exactly what to do for this. So finally, before I hand it over to our first speaker, a real heartfelt thank you to Lily. So we really appreciate Lily was able to support an educational grant for this bootcamp. So again, just a huge thank you to Lily as our sponsor for this. And a quick throw for all of you who are new, we will have exhibits open that all of our sponsors will be at. So we really highly encourage everybody at some point during the next 3 days, make some time just to visit exhibit hall and to thank all of our industry partners for their support. Again, Lily, especially for this activity. And then I'm going to hand it over to our first speaker, Shana, who's going to do an overview of IBD.
Good afternoon. I'm Shanna Arnold. I'm a physician assistant in Kansas City area. And I'm going to be talking about risk factors and pathophysiology of IBD, as well as burden of the disease. My disclosures. So IBD is a global disease. It first emerged in the northernmost parts of North America and Europe and kind of migrated south from there. And we can see that this gradient still persists today. In 2019, the highest prevalence of IBD per 100,000 people was in Norway, followed by Sweden and Canada. And then but the incidence has really kind of stabilized in Western countries and has really increased lately in more newly industrialized countries. So as of 2019, there were about 4.9 million estimated cases of IBD. It's a little hard to estimate in some areas, but that was up from about 3.32 million in 1990. So that's a 47% increase over that 29-year span. And, you know, when patients are diagnosed with IBD, in addition to wanting to know kind of what to expect over the course of their disease, patients really want to know, you know, how did I get this? And the pathogenesis of IBD, there's been a lot of gains made as far as that goes, but there's still some questions remaining. And so the short answer is that IBD results from a dysregulated immune response to environmental triggers in a genetically susceptible person. So we can say that in more patient-friendly terms. We can say, you're genetically susceptible and your immune system is responding abnormally to environmental triggers, and kind of put that in a way that patients understand about their immune-mediated disease. And so it's really this perfect storm of these 4 factors you see here. So we'll talk about each of them in more detail. So starting with genetics, the single greatest risk factor for developing IBD is having an affected family member, so specifically a first-degree relative like a sibling or mother with the disease. However, most patients with IBD don't have an affected family member. Only about 8 to 12% do. And we know that there have been more than 240 genetic risk loci associated with IBD. Some of them are more specific for Crohn's, some specific for UC, most kind of associated with both conditions. And about 60% of those are also associated with other immune-mediated disorders like celiac, psoriasis, ankylosing spondylitis. And and then let me talk about the NOD2 gene. NOD2 was the first gene found to be associated with Crohn's. It's interestingly just associated with Crohn's in European and African American population, but that was discovered in 2001. And we know that in those populations, NOD2 is associated with ileal stricturing and more disease, or increased disease severity in general. And we can test for NOD2 along with other markers to kind of help predict disease prognosis. And interestingly, though, many people carry IBD-associated risk genetics, but only a small percentage go on to then develop IBD. So that points to the significant role of environmental factors. And I really like this illustration of how IBD is thought to develop. So we've got the genetically susceptible individual, and then this complex combination of environmental factors, microbial factors that result in disruption of the epithelial barrier, and then invasion of some of these intraintestinal microbes, even commensal ones, into the lamina propria, resulting in kind of abnormal immune system activation, activated inflammatory cascades, and then resulting in mucosal damage and kind of this chronic cycle of this. I think that's a nice picture there. And so I really find the environmental factors very interesting. I think it's something that isn't focused on much at all. And I know that previously I hadn't learned a lot about, so I kind of want to go through these in more detail, and any questions after the fact, or if anyone wants to talk about it, I think it's so interesting, so I'd be glad to. But starting with smoking. So smoking is the #1 modifiable risk factor in Crohn's disease. Smokers have 2 to 5 times increased risk of getting Crohn's disease. And we know that smoking also increases the severity of the disease. So not only does it put a person at higher risk, but they have worse disease, more surgery, worse outcomes, more flares. And smoking has long been associated with a decreased risk of UC. So that's kind of confusing. But there are some thoughts there. I guess nicotine inhibits kind of Th2 cell function and doesn't have an effect on Th1 cell function. So, could that be part of it? And then other thoughts about smoking and Crohn's. It negatively affects immune system function, decreases blood flow to the intestines. So #1 modifiable risk factor for Crohn's, no smoking. It also turns out that where we live can impact our risk of getting inflammatory bowel disease. So IBD risk is higher in urban versus rural areas, also in higher SES versus lower SES populations. And there's a lot of things that go into urban living, right? Like maybe there's lifestyle factors, dietary wise, perhaps more exposure to ultra processed foods. And then also there's the hygiene hypothesis. So this theory that early in life, if we don't have enough exposure to pathogens, that this could cause immune system dysfunction later in life. So could that also play into this complex kind of, again, chain of events that lead to IBD? We have to talk about diet. We know that the nutrients that we ingest directly affect our gut epithelial barrier and gut immune system function. And so fiber specifically. So fiber is known to protect the integrity of the mucosal barrier, in part because fiber is metabolized to short chain fatty acids, which have that effect. And so yes, high fiber diets are protective against IBD, whereas low fiber diets tend to be a risk. And so a diet that doesn't have enough fiber in it, sometimes the colonic bacteria will actually utilize the mucus layer of the intestine as an energy source, and that causes intestinal damage and disruption. We know that vitamin D plays a role in immune system function and inflammatory responses. So low vitamin D is also a risk factor for IBD. Ultra processed foods, we kind of talked about that. You know, they don't have fiber for the most part, but could there be other things at play there, like food additives? Certainly some emulsifiers like polysorbate 80, cellulose gum have been evaluated as causing inflammation in genetically susceptible mice. Okay, so that's something that needs to be looked into in humans. But there's questions there as far as, is it, you know, what is it about ultra processed foods that could put people at higher risk? Specifically, increased intake of fruits and vegetables is associated with a lower risk of IBD. We know that breastfeeding confers immune factors and essential nutrients to the infant, setting them up for a healthy gut microbiome, and therefore has a protective effect. Tea and coffee consumption had a protective effect against IBD just in Asians in the studies. That's what that shows. And then I also find the appendectomy situation to be really interesting. So just the end of last year, there was a huge meta-analysis published that kind of confirmed an increased risk of Crohn's disease post-appendectomy and decreased risk of ulcerative colitis. So, you know, the appendix it used to be thought that it just had no function, so we can just get rid of it. But now we know that the appendix plays a role as in the gut immune system, and it also serves as a reservoir for beneficial bacteria to help repopulate the gut after acute GI infections. So I think I went over all that. Having pets is protective. You know, one thing that's not on here, and that's because there's no good consensus, is psychological stress. I mean, please raise your hand if you've had an IBD patient feel that their stress exacerbated their symptom. I mean, absolutely. Now, what about onset, right? So some patients will say too, so anecdotally, patients will say like, well, this happened when I was going through this really hard time. And while there's not, again, solid data to support psychological stress as a risk factor, we know that stress does affect, you know, your gut microbial balance and immune system as well. So a question of could that be part of it? So this just kind of illustrates the same thing we saw on the prior illustration of what exactly is happening in the pathogenesis of IBD. So we have epithelial damage, the disruption of the single layer cell barrier triggered by something or potentially a combination of things that causes increased inflammation driven by intestinal flora, failed immune regulation. So the failure to control that inflammatory response is really key. And then high levels of pro-inflammatory cytokine production. And the immunologically speaking, the dysregulation between the kind of innate and adaptive immune system is really, really complex. Kind of a closer look here, we can see the dendritic, and we'll probably see this in talks after mine as well, but the dendritic cells produce these pro-inflammatory cytokines, so like IL-23, TNF, which we know are drivers of inflammation in the gut. And then just interesting to know too that Crohn's is a Th1 mediated response, and there's a Th2 mediated response in ulcerative colitis. And then also here and kind of zoomed in level is recruitment of circulating leukocytes to the epithelial layer, just kind of perpetuating that inflammation. Oh, Th2, Crohn's is Th1 mediated and UC is Th2. So kind of switching gears to talk about the burden of IBD. Between 2010 and 2017, there were more than 1 million Crohn's-related and 700,000 UC-related hospitalizations in the U.S. And then the graph on the other side shows kind of risk of IBD-related surgeries over time. So this was a meta-analysis of 44 studies after the year 2000, and after 10 years of diagnosis, there was a overall 26.2% chance of Crohn's-related surgery and 9.6% chance of colectomy for ulcerative colitis. And while these numbers are substantial, they are significantly decreased from prior to 2000. So that likely lends to more advanced and effective treatments that are available. And most of the time when we're talking to patients, we're talking about their gut-related IBD symptoms, but we also know that patients with IBD have higher levels of anxiety and depression, a lot of fatigue, even when their disease is in remission. And these things really negatively affect their quality of life over time, mentally and physically. And so this was a survey from about 2,100 patients with ulcerative colitis, and just really staggering numbers as far as, 2/3 of these patients reported that they spend more time in the bathroom than anywhere else during the day, average of almost 9 trips to the bathroom, and almost half of patients needing to wear some type of protection of their clothing because they're afraid of having to have fecal incontinence. And then this survey also showed that the top 3 symptoms in the prior month that were reported were diarrhea, bowel urgency, and increased stool frequency. And we can kind of see the numbers there between the patients in the US versus Europe. This was a much smaller survey, but similar symptoms again in the past 3 months. Lots of diarrhea, bowel urgency, increased stool frequency for these Crohn's patients. And more than 50% of patients reported that their Crohn's affects most aspects of their daily lives. And again, nearly half having to wear, a diaper or pad of some sort. So as we talk about managing IBD and treatments and all the exciting stuff, just important to kind of understand the burden that these conditions have on patients. So in summary, IBD is a global disease. It stems from complex interactions between genetic and environmental factors and their effects on the mucosal immune system, gut microbiome, and resulting immune dysregulation. And IBD continues to impose significant burden in terms of hospitalization, surgeries, and patient quality of life. Thank you.
Hi, everyone. My name is Allison Crestapentis. I'm a nurse practitioner at Beth Israel Deaconess Medical Center in Boston, Massachusetts. And I'll be talking about IBD symptoms, a focused history, and the workup in a case-based approach. These are my disclosures. So starting the IBD workup. You have a patient sitting in your office with IBD or told that they may have symptoms and you have to do an IBD rule out. What you want to do is take a nice focused history, comprehensive physical exam, check on some labs and stool studies, and possibly do an endoscopy or cross-sectional imaging. So the focused history, you have a patient sitting there in front of you. What are some things that you want to get out of this so you can make the next steps and next decisions? We want to pull out our old cart mnemonic and start with the onset. Does this patient have IBD? Are they being treated for IBD, or is this something that we're looking into diagnosing? You want to get really into the nitty-gritty of their stool frequency. Are they having more bowel movements? What is their baseline? Is the consistency different? Are they having blood in the stool? Oftentimes I'll ask the patient to define blood in the stool. Is it when you're wiping? Is it mixed in with the stool? About how many bowel movements is it mixed in with? More than half, less than half, that sort of thing. You really want to get down into the details. Are they having urgency? Are they having to run to the bathroom? Are they not making it to the bathroom or having any accidents? A big sort of key indicator that should put your radar up is having nocturnal bowel movements. So waking up in the middle of the night out of a sound sleep to have a bowel movement or with abdominal pain. Other associated symptoms, we want to see if they have any extra intestinal manifestations, such as joint pain, sores in the mouth, any rashes, change in weight or appetite, and also are they experiencing any fevers, chills, night sweats? Want to understand their past medical history. So if they have any previous GI issues, if they have this diagnosis of IBD, if they've had any surgeries for that, if they have a family history of inflammatory bowel disease, those first-degree relatives, there's a potential chance for that. And then if they have any other immune-mediated diseases. Any changes in their diet? Are they trying new diets? Are they incorporating dairies? Anything that could trigger diarrhea? Have they traveled recently? We want to start to think, could this be infectious? Have they had any recent sick contacts, whether it be GI illness or otherwise? Are they experiencing an increase in stress? Because that can certainly play a role in GI symptoms. And then have they had any changes in alcohol intake or tobacco use? All right, so physical examination. After you get that thorough history, you'll want to have them hop up on that exam table and do a sort of comprehensive physical exam. You probably already noticed in sitting there chatting with them whether they look like they're in distress, any dehydration, malnutrition, pallor. So you want to document that and see what their vitals are. Are they tachycardic? Do they have a fever? Is their blood pressure high? And then you'll have them go do an abdominal exam. You'll listen for bowel sounds, hypoactive or hyperactive bowel sounds. If there's concern for obstruction, that might change. Do they have any tenderness? Whereabout is the tenderness? Is it acute tenderness, pinpoint? Are they having any rebound where you're concerned that they need to be seen more urgently? And then are they having any bloating or hepatosplenomegaly, anything like that? If a patient has known Crohn's disease or has perianal involvement, you'll definitely want to do that perianal examination. Any new patient I have in my office that we're ruling out IBD, I do a perianal exam. Often people don't want to talk about those symptoms, so it might not come straightforward in that history, but you want to have a look for any fissures, abscesses, or fistulae openings. And then other exams would be a joint exam, having a once over of their skin. Do they have psoriasis, erythema nodosum, things to look out for in IBD, an eye exam and a mouth exam. So you did that thorough history, thorough physical exam, and now you're sending this patient for labs. Sort of those standard labs of a blood count to rule out any anemia, leukocytosis, a thrombocytosis. Do they have any electrolyte abnormalities, specifically with having a lot of diarrhea? Do they have any elevated liver enzymes? We start to think PSC. Albumin, if there's concern for malnutrition, vitamin levels, vitamin D, B12, a lipid panel sometimes, and then also want to rule out something like celiac disease, so TTG and an IgA. Sort of my key things that I'm looking for is these biomarkers. I think it's a great first step. So C-reactive protein, I usually use the CRP, ESR is used in some other institutions, and then the fecal calprotectin, which is a very gut-specific inflammatory marker. We want to keep in mind that the C-reactive protein can be a good indicator, but about 20% of people do not bump a C-reactive protein response. So you'll want to look back at their prior lab, see if they have had an elevated CRP in the past, but that calprotectin is sort of the key thing. And if a patient does have diarrhea, we want to rule out C. diff, and we also want to rule out any potential stool pathogens. I'm always thinking, what's the next step here? Is this patient on a biologic? Am I changing them? Are they on sort of a mesalamine type therapy and they possibly have to be escalated to a biologic? Or are they sick enough where they don't have a diagnosis, but if they do, they might be going straight to a biologic or novel small molecule. Oftentimes I'll do hepatitis serologies, A and B and C, and then an HIV antibody and antigen and make sure their TB test is up to date. So with first diagnosis of IBD, if we're concerned for that, we want to do a full colonoscopy with TI intubation with biopsy, because that's the gold standard for diagnosis of inflammatory bowel disease. If a patient has ulcerative colitis and has a severe flare, sometimes I'll do just a sigmoidoscopy. And if they have any upper GI symptoms, we're doing that upper endoscopy, because as we know, Crohn's can be anywhere from mouth to anus. If we sort of do the upper endoscopy and colonoscopy and still have concern for inflammatory bowel disease, but those tests don't show anything, we'll do a capsule endoscopy to see if there's any inflammation in the small bowel that we could not reach with that colonoscopy and upper endoscopy. And then, as I said, colonoscopy with biopsy and histology is the gold standard. We're looking for any chronic inflammation and then any sort of changes in architecture. And if there is concern for outside of the colon inflammation, we're doing an MR or an MR enterography or CT enterography, which is sort of dedicated small bowel imaging. If they have known perianal disease or perianal complaints, an MRI of the pelvis is very helpful. And then a newer kid on the block is intestinal ultrasound. Some practices are implementing that in their day-to-day for workup. All right, so our first case. Mrs. C is a 32-year-old female presenting with a 5-week history of progressively worsening bloody diarrhea. She was first having 3 to 4 bowel movements a day with occasional blood and she's now having 8 to 10 liquid, all bloody bowel movements daily with extreme urgency, accidents, tenesmus, and waking multiple times a night to have a bowel movement. She's had similar symptoms on and off for the past 8 years, but they've always self-resolved. She's fatigued and reports a 7-pound weight loss, which she attributes to eating less because she notes every time she eats, she has urgent bowel movements. Okay, so her surgical history entails an appendectomy at age 15. Socially, she's a non-smoker. She drinks occasional alcohol, no illicit drug use, and she exercises regularly. She's an overall healthy female, aside from these symptoms. She has no family history of IBD or colorectal cancer, and she denies recent travel, sick contacts, antibiotic, or NSAID use. On exam, she's well developed. She appears fatigued and pale. Her blood pressure is normal, as is her heart rate and temperature. When you do an abdominal examination, she has mild tenderness in her lower left quadrant, no guarding, rebound, or masses. And then her bowel sounds are normal, and she has no evidence of perianal involvement. Her labs are as follows, noting the C-reactive protein being elevated, as is the fecal calprotectin. So this, to me, triggers the need for a colonoscopy to evaluate a little further. Her colonoscopy shows continuous erythematous and friable mucosa with an absence of vascular patterns and erosion extending from the rectum to the splenic flexure. So if you're Mayo scoring, this is a Mayo 2. No inflammation in the visualized ileum. And then the biopsies of the descending sigmoid and rectum show chronic, moderately active colitis with no granuloma or dysplasia identified. So Mrs. C just got her diagnosis of ulcerative colitis. This is based on her clinical presentation, endoscopic, and histologic findings. Some key takeaways for ulcerative colitis is we're often going to see that bloody diarrhea, the inflammation in the colon. That's sort of the first tip-off, and elevated calprotectin, too, is something to be on the lookout for, always keeping in mind that an infection can also trigger an elevated calprotectin, so you want to rule out other infectious pathogens. Symptoms can be acute and come on very quickly, or they can kind of be that on and off, self-resolving, and then this time really kind of tipped it over the edge. And we always want to consider those other possible conditions, whether it be infectious, functional, and the like. So now we have Mr. W. He's a 46-year-old male. He has a history of ileal and colonic Crohn's disease, which was diagnosed at age 18. He's status posted ileocolic resection at the age of 25, and he's been in a deep clinical remission on infliximab every 8 weeks for many years. He comes to you with a new onset of fever, chills, diarrhea, abdominal pain, cough, and headache. He saw his PCP, who said, "This might be your Crohn's, go see your gastroenterologist." His baseline is loose stool, but he's noticed a couple more a day, and it's more liquid. He has no blood, and the urgency is a bit more urgency. And as mentioned on the last slide, he had ileocolonic resection at the age of 25. He previously smoked tobacco, but endorses that he has not started. Again, he does not use tobacco anymore, and he rarely uses alcohol and has no illicit drug use. He does have a paternal uncle with Crohn's disease, but no family history of colon and rectal cancer. And he denies recent NSAID use or antibiotic use, but he does tell you about this great Caribbean cruise he just went on. In general, he's well developed, mild distress. He's really, really worried that this is a Crohn's flare, and he's been doing so well on the Remicade. He has a low-grade fever. His heart rate is up from the normal, and his abdominal exam is not remarkable. And you have a look at his bottom, and everything looks okay. His labs show a quite elevated C-reactive protein, but his fecal calprotectin is normal. He was at the tail end of his Remicade, sort of 8-week infusion period cycle. So we checked his trough level, and that was very good, and he hadn't developed any antibodies. We always want to look back and make sure they're taking their medicines too. That's also a key thing to take in a history. And in reviewing his record, you see that he actually just had a colonoscopy, and it was 3 months prior, and it showed a Rutgers score of I0, which shows no inflammation. And he had an MRE not too long ago, the year prior, that showed no active disease, no evidence of stricture, fistula, or abscess. So for all intents, this patient has been in a deep remission for quite some time. So what you're thinking is this might not be his Crohn's disease. So let's hold off and kind of wait a minute and see how his symptoms go. I asked him to stay in close contact with me and give me an update in a couple of days. And he calls you and says, he unfortunately got diagnosed with COVID, as did the rest of his family, possibly from that Caribbean cruise. So this is not a Crohn's flare, and he was very reassured to hear this. But this sort of emphasizes the fact that oftentimes when people present with these GI symptoms, the first thing to jump to is, oh, this must be my IBD. And we always want to rule out other potential causes. But also keeping in mind that having a GI infection or even just any sort of infection or having any sort of infection can actually trigger a flare. So you want to keep in really close contact with the patient and see if anything's changed. What I would do here is trend to C-reactive protein back to normal. And if he's still experiencing bowel symptoms, even repeat that fecal calprotectin in a few weeks. What you want to do is put all the pieces together. So in summary, importance to get a thorough history, a comprehensive physical exam, get that objective evidence with the fecal calprotectin and C-reactive protein, have a look inside and see if there's any inflammation, with biopsy, and then if indicated, cross-sectional imaging or ultrasound. And all in all, you want to take sort of a multidisciplinary approach for optimal patient care. Thank you.
Hi, hello. Welcome, everyone. It's great to be here. My name is Jamie Brogan. I'm a nurse practitioner. I work at Northwestern in Chicago. I work almost exclusively with the adult IBD patients in the outpatient setting. And I've been doing that for about 10 years. I mention that only because I got to witness a lot of this timeline that I'm about to talk about. So I get to talk to you guys about management, and really I'm going to be focusing mostly on what drugs we have available. So what I'm going to do is basically take the puzzle box and dump all the pieces out, and my colleagues are going to tell you how to put those pieces together. So get ready for some fun. Everybody's favorite, right? These are my disclosures. I'm actually going to skip over that and go back to it in a second. So I'm very briefly going to touch on conventional. Maybe it's because I don't deal with a lot of conventional therapies. Maybe it's because they're really mostly only appropriate in our mild patient population. So let's just briefly touch on them. So 5 ASAs, again, really mostly appropriate. They say mild to moderate, primarily mild patients with ulcerative colitis. Notice I'm not mentioning Crohn's on that one. They do come in oral, rectal, formulations as well, which I'm going to talk about again in just a second. And they can be used in conjunction, especially if you have somebody who has pancolitis and maybe a little bit more inflammation in the rectum that you have to kind of attack with the suppository just to really bring those symptoms down. Of course, we use steroids in our world, a necessary evil, unfortunately. They're great at getting our patients better. They're really great when they have more severe symptoms, specifically talking about prednisone, when they have disease outside the gut, if they have joint involvement, extraintestinal manifestations, or really severe symptoms. We also have budesonide, which I'm going to talk about again in just a minute, as sort of a step up from our therapies, but not full dose prednisone, which can be effective in managing symptom flares. And then we have thiopurines, which I just want to point out, they're not effective to be used as an induction. So you still need to have your patients on a steroid if you're going to utilize a thiopurine as a monotherapy and just bridge them that way. But steroids, again, are really a bridge. So make sure you've got somewhere for that bridge to go. So going back to budesonide, so these are the oral formulations. So budesonide is used in an oral formulation for Crohn's disease that will release in the end of the small intestine and beginning of the large. So this is really just to focus on the idea that you need to know your patient's phenotype, and really it's all about real estate, right? Where are we trying to attack? So if you have a patient who has proctitis and you put them on Entocort, or sorry, the budesonide 3 milligrams, it's really not targeting the area that you need to be focusing on. And, sometimes we'll call in a prescription for the extended release for a colitis patient. And the pharmacy will call us and say, hey, we can't approve that one, but we can do the 3 milligram one. Is that okay? No, it is not. So sometimes explaining that to whoever's trying to cover it or try to fill it for your patient incorrectly. So the MMX, or the extended release budesonide, will release once it gets to the large intestine. And the primary difference between our prednisone and our budesonide is potency, right? So this is more appropriate for a moderate flare, not somebody who's waking up 20 times at night to have bloody bowel movements, right? But somebody who's not quite gaining the control they need as they start on a new therapy or having some mild breakthrough symptoms. You'll also see less systemic absorption with these, and so you're avoiding some of the unfortunate side effects that we see with systemic corticosteroids. If you have a patient who's maybe diabetic and has poor sugar control, doesn't have super severe symptoms, this is a really nice option. Budesonide or rectal, or you can also use hydrocortisone in rectal therapies as well, also a real estate conversation. You have somebody with proctitis, a suppository is going to target that 15 to 20 centimeters that you're looking for. An enema is going to target the whole left side. So it's not, oh, there's more drug in the enema, I'm going to do that one. You're really thinking about where are you targeting. So if you need to get the whole left side, you need to be favoring an enema, even though it might be preferable for the patient to use a suppository because it's easier. You really need to target that area of disease. So the timeline, we have had so many exciting advancements in the world of IBD in the past few years. So we see our conventional therapies off to the side, and then we first had biologics in 1998 with the release of infliximab. Primarily, we see mostly anti-TNFs until 2014. So that's actually when I started working in IBD. So I've seen a big change after that. We see several new agents approved, and there's 1, 2, 3, 4, 5 in just the last 4 years, actually now 6 as of yesterday. We have another one. So just a lot of new opportunities and a lot of change, which can be exciting, but understandably scary. When do I use what? How do I use what? What are these new drugs? So that's what we're kind of focusing on here. So some of these new drugs are biologics. Some of them are called small molecules. What's the difference? Small molecules are small. They're small molecules. They're simple and well-defined, whereas our biologics are large, complex proteins. The small molecules are going to be an easy to replicate chemical synthesis, and they're available in oral formulations, whereas our large, complex biologics are from a living cell, and they can only be administered currently in intravenous or subcutaneous formulations. And then there's the question of immunogenicity. So that's the ability for the body to form antibodies, which can help defend it against foreign things like complex proteins. So you can build up an immunity to the medication. So that's a risk factor with our biologics. And that's why we're kind of monitoring. We'll talk a little bit more about immunogenicity later. So the first class of drug, we're just going to break it down by classes here, is the TNFs. So TNFs are great. They were first to the market. They work really fast. We love them when we have tons of experience, which is why we feel so comfortable with them, right? They work quickly, so they're often used in our hospitalized patients. And TNF is primarily, sorry to talk more specifically here, is binding to the membrane-bound insoluble TNF, which are regulators in intestinal inflammation. But it's important to know that TNF exists outside the gut, which is why it impacts what we're dealing with when it comes to the safety profile as well. But reducing surgeries, infliximab is going to be our first line. You have a patient in the hospital with a severe UC flare and they're facing the OR. We're going to see if we can save that colon with some infliximab. It works fast. It's a great medicine for your hospitalized patients. But it's also really great for complex disease. It still has the most data available to date on fistulizing disease. So it still is a preference. So knowing your patient's phenotype, how their disease likes to act, is an important level of understanding of the disease when you're trying to choose your medicines. So I'm just dropping these in. I'm not going through the ins and outs of every single clinical trial for every single medicine that's approved for Crohn's. We would be here all night. Nobody wants to hear me talk that long. So I just want to mention them so you can see them, and you guys will have access to these slides afterwards so that you can reference back to them. I include them just to show the level of clinical remission for each of these agents, which are infliximab, adalimumab, golimumab, and certolizumab. So they're so great. We use them in our hospitalized patients. They help with visualizing disease, which is so hard to do. So what's the problem, right? We go back to that immunogenicity. There's higher risk of immunogenicity. We see those antibodies forming a little bit more often in our patients on TNF agents. So monitoring for those, being aware of those risk factors is important. Some patients just don't respond to TNF. Some patients respond great and then just stop. So sometimes we know why, it's because they formed antibodies, and sometimes we don't, because their disease may be caused through other immune pathways. And that's why it's been so great to have some other options targeting different cytokines. So kind of our pro-con list, risk-benefit list, if you will. So again, work quickly, visualizing disease data, those severe patients, also extraintestinal manifestations. If you have patients with pyoderma, if they have uveitis, TNFs are still our favored option for those kinds of patients. And they've been around a long time, so we actually have some pregnancy data and lactation. So we feel comfortable using it in our patients who are on their family planning journey, whether they're thinking about getting pregnant, they already are, they just have, whatever it is. We do have to think about infection risk. So patients who currently have an infection, you're going to have to wait for that to clear before you start them on it. Screening them for tuberculosis and hepatitis B. We can monitor levels for all of our TNFs, which will also include an antibody level. If you have a patient who's at risk for forming antibodies, let's say you've had them on a TNF before and you're going to start another one, thinking about the SONIC trial, some of the other things that we've done to look at the concomitant use of an immunomodulator, so using a thiopurine with that TNF can help potentiate the effect of your TNF, so higher levels, and help it work better, but also be protective against forming antibodies. If you know your patient has a propensity for it, you're going to want to go ahead and start them on a concomitant therapy. We do want to think about our patients who have a history of lymphoma or screen them for it, or melanoma. And any use with a current or prior malignancy, you're going to want to really think closely about those patients before recommending a TNF. So these are most of the TNFs. So I say most because for both infliximab and adalimumab, there are also biosimilars, which are the same as what these ingredients are. So infliximab, the originator name is Remicade. Many people still refer to it as that. But it's available for IV induction and maintenance. But there is now an injectable version of infliximab where you do an IV induction and a maintenance with a subcutaneous injection at home every 2 weeks. Adalimumab, Humira is the originator, but there are 10, maybe 11 at this point, biosimilars available. They are all adalimumab, so work the same way. That is an induction dose where you do a higher dose on the first couple, so 160 milligrams, 80 milligrams, and then you go to the 40 milligrams every other week. For certolizumab, it's 0, 2, and 4, all subcutaneous dosing. That is exclusively available for patients with Crohn's disease, and golimumab is week 0, 2, and 4, and then every 4 weeks, but only for our UC patients. You have to know your indications. So if you're trying to get something for a Crohn's patient, it's only approved for ulcerative colitis. You're going to have barriers in access to that medication for your patient. Delays in care lead to progression of disease. We're going to transition and move forward to vedolizumab, which is an anti-integrin. So this is an alpha-4 beta-7 integrin. Basically, this is going to connect with receptor cells that line the gut, MADCAM cells. So it's blocking inflammatory cells that are naturally in your circulation from going into your gut, which is why they call it the gut specific, right? This is beneficial when you think about patients who have issues outside of their gut. It's also maybe not the most advantageous for people who do have issues outside the gut that you need to be targeting. So just kind of how we think about these medicines. The Gemini trials are the ones that you're going to want to reference when you're looking at these. We again see clinical remission rates. You'll notice on here that the original trials, the Gemini one, actually did look at an escalated dose of Q4 weeks. So if you are trying to look for an off-label dose for a patient who's responded but not been able to achieve a remission, that even original trial will help give you that evidence you would need for your prior authorization. So safety, again, safety. And just as a side note, I actually use this for patients with immune checkpoint inhibitor-induced colitis. So basically patients with cancer who are experiencing an IBD-like response, we feel comfortable enough using this medicine on them off-label. Very low immunogenicity. So we talked about that higher risk with our TNF. It's very low. Maybe 5 patients in my experience have ever had that. Using a concomitant immunomodulator is not going to potentiate vedolizumab. It's not going to raise your trough levels. If you have a patient who's starting to build antibodies, it can help with that, but that would be really our only consideration for it. And again, that's extremely low. And limited data on EIMs and any other immune-mediated issues. So if you have a patient that has multiple immune issues, they have psoriasis, they have RA, and they have an IBD, Entyvio will help potentially their IBD, but it won't affect anything else. So when you're thinking about treating a patient, kind of take a step back and think about those other things. Also, again, a patient severe enough to have uveitis or pyoderma gangrenosum, this has not been supported for effective use in those. It is been available intravenously since 2014. You do a loading dose weeks 0, 2, and 6, and then every 8 weeks. Within the past few months, they have released a self-injected pen that you can use for the maintenance component, which is 1 injection every 2 weeks. Sorry, and available for both ulcerative colitis and Crohn's disease. We're going to move to our anti-integrins. So these are IL-12/23s and then the IL-23s as well, so all anti-integrins. Binding to the P450 subunit of IL-12 and 23 for the IL-23 and just the P19 for the IL-23s. So here is the clinical remission rates. Again, we see for ulcerative colitis and Crohn's disease in the UNITY trials. Oh, sorry. And you'll notice that they have 12 weeks on here because they looked at 12 weeks, but we know that the approved dosing schedule is every 8 weeks for the maintenance. So safety, we know it's pretty safe, and the more we use it, the safer it seems to appear to us. Very low risk of immunogenicity. Again, same consideration. Don't have to use an immunomodulator with it, only if you are starting to notice some low levels of antibodies, which again, extremely rare. I think it's less than 7%. This is also utilized in psoriasis and psoriatic arthritis. So if you can have a patient with another condition, you can utilize this as well. Appropriate to use in bio-experienced as well as bio-failures, but not a lot of data for EIMs. It's a one-time IV dose and then a subcutaneous dose every 8 weeks thereafter. Approved for both UC and Crohn's. We have risankizumab, which here you'll see is approved for both ulcerative colitis and Crohn's, but you'll see a new thing on here. Not only did they look at clinical remission, but endoscopic remission. So this is we're starting to see this tie-in of the STRIDE 2 guidelines, where we're starting to look at not only the subjective data, but the objective data of the patient. So making sure that not only are they feeling better, but their tissue's looking better too. And then they looked at that in the clinical trials. Mirikizumab also looked at clinical remission and endoscopic remission. It is currently approved for ulcerative colitis. We've included the Crohn's data, hopefully soon. We will see that indication come through. Mirikizumab also looked at urgency data, which, as we know, anybody who treats patients, particularly with ulcerative colitis, urgency seems to be the most difficult for them to manage and function normally in life. Going out to dinner, going to work. That risk of loss of control is probably one of the most impactful that we see. So they actually looked at the efficacy of this agent on urgency as well. So showing 40% of patients were able to have resolution or near resolution at that 40-week mark. Safety. Again, we're seeing infection risk. We're talking about changing how the immune system works. We are going to see a risk for infection. You're screening your patients for infection before starting them. Headaches, arthralgias, elevated LFTs that tend to resolve, but definitely something you want to check in on, but pretty standard stuff here overall. And very low risk. We're seeing less than 10% on all of those side effects. So safety is great, low immunogenicity. We see some other immune-mediated diseases covered by We see urgency improved in the literature. And again, really great for bio-exposed patients as well as bio-naive patients. So when we talk about treatment, anybody who's never been on a biologic and you're thinking about starting them, they always do best on their first one. It's when they've failed 1, 2, 3, 4 other biologics that it becomes concerning to us what is going to work for them. So when you have data to show that it's helpful in patients that have been exposed to other biologics, it can be a helpful tool as a provider. And then deciding between them, time will tell. So again, the approved doses scheduled for risankizumab, it's an IV dose at week 0, week 4, and week 8. That 8-week subcutaneous maintenance dose actually starts on week 12. So make sure your patients are starting out on week 12 and not waiting 8 weeks after their last injection. And that's an on-body injector that is approved for Crohn's as well as ulcerative colitis. And mirikizumab, again, currently for ulcerative colitis is exclusively, is an IV dose for week 0, 4, and 8, same thing. And then it's a subcutaneous dose, dosing schedule every 4 weeks. We're gonna move forward with the JAK inhibitors. Sorry, I'm running out of time, guys. I'm sorry, I'm running over. So JAK inhibitors targeting the cytokine, these have been really helpful for a quick response for our patients. They work quickly, which is probably the most significant attribute that we've discussed about these to date. So we have tofacitinib currently approved exclusively for ulcerative colitis. And here we see the Octave schedule trials, and then upadacitinib approved for both UC and Crohn's disease, available in once-a-day dosing after induction. They also looked at urgency in upadacitinib. So just wanted to show this data for you, both in the induction and maintenance. We see continued improvement in urgency, and they do divide by dose specifics. So oral dosing, because this is a small molecule, so some patients are really excited about not having to go into infusion centers. It could be lack of immunogenicity is another factor. You have a patient who maybe decided they were feeling so great they went off their medicines, because we've never had that happen before ever, right? Patients don't just stop their meds. But when you want to restart them, we're not worried about them having built antibodies. So that's a real benefit of the small molecule class overall. These can be used in patients who have more severe disease. We have in our facility used them in hospital setting as well. Rapid onset, and that's beneficial not only because, of course, we want to make our patients feel better, but there's a potential to diminish their steroid exposure if they're getting better quickly. They can taper quickly, or potentially in some patients, I've actually skipped over steroids altogether. And again, that bowel urgency. We do have some infection risks. So we are making sure our patients are vaccinated for shingles and up to date on all of their vaccinations. We do a lipid panel after they've completed their induction dosing. We do see some low levels of hypercholesterolemia. And then again, just another plug, make sure your patients have PCPs. We do not use it in patients who are pregnant or planning on becoming pregnant. We don't have safety data for that as of yet. So when you're talking to young female patients about what medicines you want to start them on, make sure you're talking about family planning as well. And there is risk of malignancy. We primarily talk about the non-malignant skin cancers, but there is a lung cancer risk for patients who are current or former smokers as well. And then that MACE DVT-PE that's all capitalized and feels like it's yelling at you. That was specifically noted in the tofacitinib RA patients greater than 50 years of age who were already had at least one cardiovascular risk factor. So just being aware that it is an appropriate medication, but just knowing your patient and their other risk factors when discussing it. So again, we have tofacitinib and upadacitinib. Tofacitinib's twice a day for induction and maintenance, and upadacitinib's once a day. You start with higher dosing and drop down to your maintenance dose once a day for, ulcerative colitis for tofacitinib. It's ulcerative colitis and Crohn's for upadacitinib. Sorry about that lack of check mark there. And then we have our S1P modulators, and we fondly call this the Hotel California drug. Your lymphocyte trafficking, it attaches to them, and once they enter the lymph node, they can't check out. So they can check in the lymph node, can't check out, and wreak havoc on your intestines. So we have ozanimod with the True North data and etrasimod with the Elevate. We have data as well for etrasimod when it comes to bowel urgency. Oral dosing for both of these, they are approved for first line for moderate to severe ulcerative colitis, exclusively ulcerative colitis on both of these medications. And then again, because they're small molecule, not worried about immunogenicity. There is concern for cardiovascular. There's a risk of bradycardia, so we do an EKG before starting on them. We're checking patients' eyes, having them evaluated by ophtho to make sure there's no macular edema going on prior to starting them on therapy. If they have severe pulmonary issues, just something to talk to them and their pulmonologist about. And then we look at those LFTs, lymphocytes, like we always do with every single medicine we're putting our patients on, and we are vaccinating for shingles as well. So ozanimod is actually a dose titration for the first 7 days, and then a once daily dose. And then etrasimod is just a daily dose that you start from the beginning. There's no induction dosing. Again, both for ulcerative colitis. So just primary safety. This is just a nice comprehensive slide of what areas you're considering when talking about each of these medications. I do just want to point out, often forgotten, but shouldn't be, is when it comes to 5-ASAs, making sure that you're following up on their kidney function. Interstitial nephritis, rare, but very serious. And so making sure you're following up on that level about a month after getting them started. I think that's a quickly forgotten one. And obviously our thiopurines, you're checking their labs at least every 3 months for those. But again, just dumped out that puzzle box and we're going to put it together for you. But we have thinking about what kind of disease your patient has, whether it's a Crohn's or ulcerative colitis diagnosis, but also the disease phenotype, the behavior when they're diagnosed, because that impacts their progression and how you think about it. If they have any extraintestinal manifestations, what they've previously been on, are they biorefractory or bio-naive? Age, any comorbidities, because that can factor into what you would favor for approval on your patients. Their preferences, don't underestimate that. Patients, I've had a patient say to me like, I know I won't remember to take a pill every day. I just won't. And it was very enlightening. Or I will never inject myself with a needle. I just won't do it. It's going to be too hard for me. So having those open conversations, route of administration is a really important thing to talk about with patients. Family planning, as I mentioned. Access, making sure that they're aware of all of the support that our pharma industry friends offer to our patients. Efficacy, onset, how the durability of a medication, you can get them well, but you have to keep them well and making sure that you're following up on that. And then safety, of course, we're talking about infection, we're talking about cancer, and then those few other things we mentioned that were more drug specific. So I know I went over a whole lot with you guys and I look forward to your questions at the end, but thank you for your attention.
Anybody's brain fried yet? So I'm Gabriella McCarty. I'm a nurse practitioner at North Shore Gastroenterology. I'm in the Cleveland area and I have been there for the past 25 years. Just to Jamie's point about that timeline that you saw, I've been there from the beginning and boy, have we come a long way with IBD therapies. And just as treatment is so not black and white, it's very individualized, monitoring is too. But that's what I love about IBD is it really makes you think. And I'll get started. These are my disclosures. And I'm really honored to be amongst, presenting with these amazing women and excited to be here with all of you for this conference. So we know that getting patients under control earlier will give them better outcomes and decrease complications down the line and decrease potentially colon cancer risk later and more complicated disease. So this treat to target approach with optimum monitoring strategies is a key. So I'm going to start with a case study. And this is a 28-year-old male that I saw in February of 2020. So right before COVID hit, And he was having some intermittent rectal bleeding and on and off constipation and diarrhea for about a year. No family history. He's never had a colonoscopy, no family history of IBD or colon cancer. He saw his primary care and had a negative digital rectal exam. And, you know, since he is 28 and we know that IBD is mostly diagnosed in that younger adult, you know, we're going to do a colonoscopy. I did order some labs, and including a CBC, CMP, SED rate, CRP. And also to note, he isn't taking any medications, just some multivitamins. He was not taking NSAIDs. And he's a police officer in downtown Cleveland. And so his colonoscopy showed a severe proctitis. So the rest of the colon looked good. There was just a lot of inflammation in that rectal area. The biopsy showed chronic active colitis with ulceration, regenerative changes, no granulomas, no dysplasia. His labs were great. Colonoscopy was done, as I said, 3 days after the visit. And with that severe proctitis, and we know that proctitis is hard to treat a lot of times, but we started him on mesalamine suppositories, 1,000 milligrams every night. And the plan was to do that for a month and then go to every other night and then to repeat a sigmoidoscopy in 4 months. So I see him back in June and with worsening symptoms. And it ended up, he only took the mesalamine suppositories for 9 days. So it was too expensive, and being a typical young male, he doesn't call us or tell us this. He felt better. So he just figured he'd go on with his life and go off of them. So now 4 months later, he has severe cramping, bloating, bloody diarrhea, hourly. He's up at night. He lost 15 pounds. He had a fever of 102, and now he's been using ibuprofen, 600 milligrams twice a day for the past week. So not helping any matters here. He did get new insurance in the meantime and did start back on his suppositories 2 weeks before his visit. And he's been stressed. So now COVID's hit. He's a police officer downtown. It's the Black Lives Matters movement, and there's riots going on. So he's working like 12-hour shifts. So to the point earlier, that stress, I think, really did aggravate his symptoms. So a flex sig was planned for the following day, which ended up being a colonoscopy because he was so cleaned out. We checked labs and a fecal calprotectin. We kept him on his mesalamine, but we did add prednisone at this time at a 40 milligram taper dose, told him to stop the NSAIDs, and counseled him on fluid electrolyte replacement. So now, and there'll be a picture coming up, but now he has severe pancolitis with a Mayo score of 3. So if you see his labs on the right-hand side, he now has leukocytosis, he's anemic, thrombocytosis, his albumin's down, SED rate and CRP are elevated, and his fecal cal is over 1,000. So we increase his prednisone to 60 milligrams, and we're planning to start infliximab 10 milligram per kilogram ASAP with azathioprine 100 milligrams in order to decrease that immunogenicity. We usually would do that for a year, and then with a plan to repeat his colonoscopy in 4 months. So this is what his colon looked like. It was one of the worst colitis that we have seen. So within that 4-month time period, he went from a proctitis to a severe pancolitis. So it can happen that quickly. And so the pathology marked chronic active colitis with ulceration, no dysplasia. So he was started, we have an infusion center, so we're lucky to have that right in our office. So he was started on infliximab in 3 days at that higher dose at 0 to 6 weeks, and then every 8 weeks IV, the plan. We stopped the mesalamine. Prednisone was kept at 60 for a week, decreased to 40. With a taper dose, we want to get people off steroids as quickly as possible. And I did see him 2 days after that first infliximab infusion, and he was doing better. I also saw him. What's nice having an infusion center at your office is, when they're coming in, you could just pop over and talk to these patients. So I did see him 2 weeks later after his second infusion and felt like a whole new person. No abdominal discomfort, 3 to 4 form stools a day. And remember, we talked about the azathioprine. So repeat colon 4 months later is in remission, actually. So UC is in remission. There's these pseudo polyps, and you can see the scarring because it was so severe. So now, what do we do? So I follow these patients every 6 months, no matter what. Even if my patient on advanced therapy is doing well, I see them every 6 months because you really get to know your patients well. And I feel that you can catch some early subtle changes in their symptoms where you can kind of jump on things early. So he's still on infliximab, higher dose every 8 weeks. We stopped the azathioprine a year later. He's doing well, just checked drug levels and they're pretty good. The infliximab trough is 19.8, no antibody formation. So what do we do at this time? And this is just something to think about, and everybody's gonna say something different. Do we now decrease his infliximab dose? Do we change perhaps to a different, maybe safer therapy? And how often do we monitor his colonoscopies? So we know patients with disease for over 8 to 10 years, we need to monitor them every 3 years just due to the cumulative increased risk of colon cancer. So we're planning to repeat his colonoscopy in 3 years. I still see him every 6 months, and we are keeping him on that same dose just because he had such severe disease and he does not want to change anything with his dosing. He does not want to be back to where he was at that time. So we've all heard of the STRIDE-2 recommendations for treatment targets in IBD. So we have some short-term, intermediate, and long-term targets. So as far as short-term, within 3 months when you start a new therapy, ideally you want symptomatic response. So you want patients to feel better, and they want to feel better. So you want decrease in abdominal pain, diarrhea, and rectal bleeding. Then ideally in 3 to 6 months, you're wanting symptomatic remission. So you don't want them to have any complaints, and normalization of CRP. We'd like to see a decrease or normalization of fecal calprotectin. Then about 6 months, and we usually rescope within 4 to 6 months. We usually do a fecal cal like right before that first scope after a change in therapy or a new therapy, just to see if those levels correlate, because then we can really just follow with a fecal cal. So we like to see now endoscopic healing. We want quality of life to be back to normal, right? You want patients to be able to work without having to run to the bathroom all day or go out with their friends, or, remember, a lot of these are younger adults, so they're going to college or just starting, their careers or getting married, having kids. So you don't want any disability there, and you want to see normal growth in children. And now we're really reaching for the stars, because now we want to see transmural healing in Crohn's and histologic healing in UC. So just mentioning the objective measures we look at for disease activity. So clinically, patient-reported outcomes, Mayo score for UC, the Harvey-Bradshaw index. And we're looking at basic labs, fecal calprotectin, and then we're looking at the endoscopies, the pathology. And imaging, we will follow. So if a patient has small bowel Crohn's, or like as mentioned previously, to look for some inflammation in the small bowel, video capsule endoscopies. Again, if patients have obstructive symptoms, make sure you get that patency capsule first. And my next case is a 29-year-old female with ulcerative colitis, diagnosed in 2015. And she works as a travel nurse. And endoscopic findings initially showed actually some patchy inflammation throughout the colon and then also ileitis. So at first we were like, is this like a Crohn's colitis overlap? You know, sometimes it can be hard to tell. She did have some extraintestinal manifestations, joint pains. She had a lot of like hand stiffness, bilateral feet joint pain. She did see rheumatology and was on methotrexate for a while. And initially, you can see the ileitis there and some distal transverse colitis and rectosigmoid, but there were no granulomas, no dysplasia. And she has been through the gamut of treatments. So remember, she worked as a travel nurse. So there were times she was gone for months or a year at a time. She didn't always come back to follow with us. She would try to establish, or she would end up going to urgent care wherever she was at and put on steroid courses. But initially 5-ASAs and budesonide. She took azathioprine sporadically because, you know, nurses are notoriously, they take care of other people, but not themselves. So, and she was on infliximab for about 2.5 years, but she did not have any detectable levels when we checked those, and she had antibody formation. Although she did go on adalimumab after that, just because she wanted the convenience at that point of sub-Q injections, and levels were lower, but she didn't develop antibody there. Veto for 8 months. She had, actually, she did well at first, but she felt like she flared after her COVID vaccination. So she had significant symptoms at that time. And her CRP sed rate went up, her fecal cal was up. We tried her on ustekinumab for about 5 months. That didn't work at all. And again, like, patients are so different that it's really hard to tell like who's going to, what inflammatory pathway you need to focus on hitting in that patient. Tofacitinib for 11 months, she relapsed. And then UPA and vedolizumab. So she at first felt really good with vedolizumab, and we added upadacitinib or Rinvoq. And she did really well on that. She got into remission. Then she decided to come back home. She was very stressed. She was planning a wedding. And she actually had a lot of symptoms at this point of urgency, her diarrhea, abdominal discomfort, but she kept having to run to the bathroom. She'd wake up at night. Well, we actually put her on mirikizumab at the end of July. So at that time, you know, her fecal cal, sed rate, CRP shot up. So once we got that J code and we were able to give that in the office, she was switched to that. And within 3 weeks, her fecal cal went from 1,170 down to 256. Her labs normalized, and most importantly, she is feeling great with significantly decreased diarrhea and urgency. So mentioning subjective measures. So when we see patients in the office, we're asking about abdominal pain, diarrhea, how many times a day are you going? Do you wake up at night to go to the bathroom? And then we'll mention urgency again and a little more, because we weren't really always great about talking about urgency. At least I wasn't. You know, I'd ask about diarrhea, but not always urgency, but it is a big symptom in patients. Of course, rectal bleeding, abdominal pain, we're monitoring weights, fatigue goes along with IBD. And patient-reported outcomes, not always directly correlating to what the physician sees or thinks. We know that patients can still have active underlying inflammation, but they might tell you that they feel great. And remember that these patients have lived with these symptoms for so many years. So to them, they'll come in, if they've been having 12 loose stools a day and they're down to 6 loose stools a day, they might come in and tell you that they're doing fine. They're not having any problems. So really digging into their symptoms is important. Asking the right questions. Again, patients are embarrassed a lot of times to talk about their bowels in the first place, but especially with urgency. So just, and not only urgent diarrhea, but I ask about tenesmus as well, which is the urge to go, but you can't go. And patients don't always associate that with having diarrhea. But I kind of describe it to them as the dry heaves of the rectum. And they're like, oh yeah, you know, I have that 10 times a day. And I also ask if patients do they need to know where every bathroom is wherever they go? So kind of like the IBS type questions that you ask. Are they having to wear a diaper or a pad? And you'd be surprised, since I started asking that question, is that how many of your young patients actually do wear diapers and pads when they go out anywhere? So it's very underappreciated and it needs to be addressed. So as we saw with the mirikizumab slides, they actually do have a validated test for bowel urgency. And it goes from a scale of 1 to 10, 1 being no urgency, 10 being the worst possible urgency, and remission being less than 1. So they're following these patients and asking these questions over the past 24 hours. How severe was your urgency? So it wasn't like just a yes or no with some other studies that we're familiar with. But above a 3-point reduction was clinically meaningful improvement. So I'm just putting this there just to ask the question. It's not like we're doing an urgency scale on a routine visit or anything. So in defining disease severity, we're looking at symptoms, those disease activity scores, quality of life, patient-reported outcomes, and inflammation with labs, disease location, depth of ulceration. How many times have they been admitted to the hospital? What's the frequency of flare-ups, and have they had surgery? And this is a lot on there, but there is a disease severity index for both Crohn's and colitis, and you'll get these slides, but it really goes into, especially this is good for hospitalized patients, to go into depth. The higher the score of each of these, more severe the disease. So to really get patients treated early on. And last patient, and I know I'm running low on time, 26-year-old, putting him in here just as a reminder that Crohn's does not only affect the colon, but also this patient had esophageal Crohn's, was treated with adalimumab, and we actually switched him over to Vito just for safety profile. He's a young male. Last active disease was upper GI in 2014, though he did have surgery for a perianal abscess in 2019. He's been in remission. So kind of how do we follow and monitor? So this was his EGD showing compatible with Crohn's disease in the upper GI tract. So again, we follow him with a colon EGD every 3 years. He's had the disease for a long time. So therapeutic drug monitoring, was already mentioned previously, but it's pretty easy to do. You can do it reactively or proactively, and it's cost effective. So get that baseline exam, use the combination of subject and objective measures. And I follow patients, again, routinely, like I said. As far as labs, initially I check every 3 months, CBC, CMP, SED rate, CRP, and I'll continue to do that until they're normal. If they are normal and in remission, I get labs every 6 months. And in the future, artificial intelligence will take over everything. No, I'm just kidding. But people they'll have remote monitoring. They'll be able to virtually shoot information to you, and point of care testing. Like, they'll be able to do fecal cows at home and monitor CRP. And so there's a lot coming down the pipeline here. So get that baseline colonoscopy, baseline assessment, ask all the right questions. Don't forget about urgency, proactive monitoring every 2 to 3 months until the patient is stable. We talked about the different disease monitoring. If the symptom targets are not met, so if patients still are complaining of symptoms, but the biomarkers and colonoscopy looks good, they might have some underlying IBS, which runs hand in hand sometimes. So look for some other causes, or check a C. diff, ask if they've been on antibiotics, things like that. And then either if the biomarkers are not met, you need to either optimize your current therapy or think about switching to a different class. And what I would ultimately love to see is if somebody can develop a blood test, a genetic blood test that will tell me what the patient's disease is, what the phenotype is, and that this specific patient will do well on what combination therapy, and take all the guesswork out. That's it.
Hi, everyone. My name's Erin Darguzis. I work at Northwestern Medicine with Jamie. The pressure's on for me to put it all together for IBD therapies. But the true answer is, I don't think we can ever always 100% put it all together, right? I mean, there's so many drugs out there available now. Not one provider gets it right the first time, every time. But let's try to simplify this a little bit as much as we can with what therapies are available now. And overall, we're going to talk about disease risks and severity, efficacy, and safety. We're going to go over that, and we're going to try to go into a little data behind all of it. So putting it all together as much as we possibly can. We don't have a specific algorithm, right? I mean, if we did, we'd be done. We're good. But it takes away the human component. We can't chat GPT this, right? So disease characteristics, we're going to look to see, is the patient have Crohn's or UC? That's important, right? We're seeing how much is going to be exposed drug-wise with the disease severity. How is the behavior of the disease? Is it just left-sided UC, or are we managing Crohn's throughout the entire gut? That's going to be a choice of your drug based on that. Is this early or late in phase? Is it something where you're mild or moderate or severe, right? And then are we involving the EIMs? Is it a skin component? Is it a arthritic component? So that may be a part of your choice of drug selection. And then treatment history. Have they been bio-naive or bio-exposed? And so we'll give a little bit of data behind that. Your patient's a big factor on what they decide to choose, right? Like, we have an idea of what we like. We go in with this clinic visit and we're like, it's this, or this. And then they're like, no, I don't want to do that because I saw this commercial, So that changes everything, right? But that's the human component of IBD. That is part of our decision-making process. And so drug efficacy and safety, we're going to touch in on those as well. Jamie honed in on it a little bit. There's one brief slide here, 5 ASAs for mild to moderate IBD. In ulcerative colitis, it's found to be effective. Obviously, we can do it. We can use rectal therapy, left-sided disease, or for pancolonic disease. In Crohn's, we don't see it as effective. Okay, so as we're thinking about drugs, I think it's really important to not ignore these MOAs. We're all initially very overwhelmed. They keep popping up, right? There's all these blue little boxes that keep popping up, different MOAs, and we're like, how do these all work? take the time to really understand your MOAs. Don't be scared to learn what they are. You can even go on YouTube and there's millions of videos on MOA and you can keep rewinding and rewinding and rewinding and get a sense of what it is and what they do. Because once you get IBD pathophysiology, it really is a lot easier to understand what drugs that you can choose from. So prognosis with disease severity in UC first. You're going to look at those patients that are low risk and those that are high risk. So the patients that have been in remission for greater than a year, maybe don't have as much endoscopic involvement. Maybe, you know, they're an older patient population. We have seen like a higher spike of patients over the age of 50. So their risk over time with the disease is less. Keep in mind those low risk factors versus the high risk factors. They flare within a year. They've been on other therapies. They recently had a change in their maintenance therapy. You're seeing these endoscopic lesions that are very deep and ulcerated. So when you are thinking of a drug, think of a drug in comparison to how severe their disease is. And then again, in Crohn's, low risk, older than the age of 30, no perianal disease or stenosis. Superficial ulcerations, not those deep ulcers, no stricturing. High risk, as you can see, it's all the opposite. And one thing I would encourage you all to do, I don't do endoscopy at my institution. I don't know if you do, but I think it's very important to know what your endoscopist is defining as mild, moderate to severe. Knowing what the pictures look like, knowing what the pathology looks like, and making sure you have that communication with your physician to know how you're going to treat this disease. Take the time to really know that. Okay, so diving into safety and efficacy. So this is a model that shows some of the drugs we have available in relation to safety and efficacy. There's one red box on there for the drug. Guess which one is it? It's steroids, right? It's not the safest choice in the world. Long-term, we know it's going to cause problems. And we know we don't want to use it as a long-term maintenance therapy. But we like to use it as that Band-Aid or that rescue therapy. So it's really nice to see this little model that shows you that overall, our drugs are safe. Yes, they're immunosuppressive, but not in the spectrum of other immunosuppressive drugs. And I think that's the important thing you got to hone in with your patients that, yeah, we're going to talk about immunosuppression a little bit, but overall, the benefits will outweigh the risks when we're trying to get this disease under control. And here's a little data that has some comparisons of some therapies. The safety profile of some of these showed ustekinumab versus the TNF inhibitors, vedolizumab versus TNF inhibitors, and then ustekinumab versus vedo. And you can kind of get a sense there between UC and Crohn's. So in the first column, we saw that there was a 50% lower risk of serious infections with ustekinumab in Crohn's over UC. In the UC, there was a knowledge gap. We didn't have enough data to support that. Vedo versus TNF, 32% lower risk of serious infections with vedo based on the mechanism, right? Jamie talked about the mechanism and how that's different. We see TNF outside of that area. No difference in risk of serious infections between the two in Crohn's. So keep that in mind, okay? Ustekinumab versus vedolizumab. We don't know enough with UC, but 60% lower risk of serious infections with ustekinumab. Safety pyramid, we can't get away from it. No, this is different. So as you see in the spectrum, our friend corticosteroids are at the bottom, and then it builds up from there. But again, the important message is these drugs are safe, okay? And then patient factors affecting safety, their age. So you're going to keep in mind, is this someone that's in the younger patient population, your pediatric population? Is it someone over the age of 65? So when you're thinking about a safety component, those are things to think about. Disease classification, comorbidities, and then concurrent therapy. Mostly we see that in combination with our anti-TNF medicines with the disease severity, but what is that risk of safety when you're doing the two together? Okay, efficacy of advanced therapies in bio-naive versus bio-exposed. And this was a meta-analysis of 23 studies. It looked at clinical response, clinical remission, and endoscopic improvement. Overall, this was data that had shown that upadacitinib had great efficacy over other drugs. However, this is from 2023. Things have changed, and now we've got a couple more drugs on the block, right? New kids on the block that are not incorporated into this. So this is all going to change again. But overall, this is a great guidance when treating bio-naive and bio-exposed. Efficacy of advanced therapies in bio-naive versus bio-exposed in Crohn's disease. Little bit different because, as you can see at the bottom, a good go-to for severe Crohn's, infliximab with azathioprine as combo therapy. It's the go-to still. It's shown to be most effective. However, you still have great options in treating Crohn's. You can see from the data, infliximab monotherapy, still very effective, but then adalimumab is another option in bio-exposed. And risankizumab, one of the newer kids on the block, is also a nice option. So you have, that's the point. You have choices to treat Crohn's now. If you need to put your best foot forward in severe Crohn's, as you can see, it's infliximab, especially with azathioprine and bio-naive. But in your bio-exposed, you've got other treatments, risankizumab, ustekinumab, and adalimumab. AGA guidelines for advanced therapies in patients with moderate to severe disease, and it's been broken down between UC and Crohn's. Now, as you can see, upadacitinib and the IL-23 inhibitors have not been included in guidelines, but AGA guidelines are going to be updated, I believe, in December of 2024. So this is just what current guidelines show at this time. In UC, infliximab or vedolizumab rather than adalimumab were the drug of choice in the bio-naive patients. For primary anti-TNF non-responders, ustekinumab or tofacitinib rather than vedo or adalimumab in UC. And then finally in Crohn's, bio-naive, your choice, infliximab, adalimumab, ustekinumab over certolizumab. And then in the primary non-responders, it'd be ustekinumab. Those are the current guidelines. And the secondary non-responders would be adalimumab or ustekinumab for Crohn's. Then we look at endoscopic healing of the ileum and colon in Crohn's. So it's nice to see clinical remission, clinical response. What does endoscopic look like? This was a pooled analysis. It had about a 300-page 299 with Crohn's disease in 4 clinical trials. Efficacy of adalimumab, infliximab, ustekinumab, and vedo after 1 year of therapy. And what did it show? Endoscopic healing at 1 year, anti-TNF favored over vedo versus ustekinumab. Those large, deep ileal ulcers we talk about, infliximab was more favorable. And then colonic disease, we saw adalimumab and infliximab over ustekinumab. Again, this is just one pool of about 300 patients. Head-to-head trials, it's kind of becoming the new thing where we check comparison data, right? So this is just a nice summary of some of those that are out there and available for you to have to review. We have Varsity, where it looks at UC patients on vedo versus adalimumab. CVU is Crohn's disease in the bio-naive patients, and that had shown that there was no favoritism of ustekinumab over adalimumab as far as safety and efficacy. Evolve was UC and Crohn's in bio-naive patients. And you can kind of read along the way there, but this is a nice reference tool for you when you're thinking about a drug of choice. You can use it to see, is this something that might be a good option when we think of one drug that maybe there's multiple choices? We've talked a little bit about therapeutic drug monitoring. And when I'm talking to a patient about these drugs, I actually think therapeutic drug monitoring is a good tool. It's not the end all be all answer. So if my drug level is low, it doesn't necessarily mean I'm going to always adjust dosing, right? Like if they're doing well and feeling well, I might keep them as they are, but it's good to have that in your back pocket if you ever need to adjust dosing, and fight insurance for it. So I did want to give you at least a reference guide of some of the recommended drug levels. This is AGA at this point, and this is all reactive therapeutic drug monitoring. There really is no proactive drug levels that are approved by AGA at least, or guidelines. So as you can see, infliximab greater than 5, adalimumab greater than 7.5, certolizumab greater than 20. We don't know with golimumab, but again, these guidelines are going to change. Limited data available for ustekinumab in Vito, but I just wanted to put some kind of info out there that target level at week 8 should be anywhere between 3 to 7, ideally. Again, you're going to look at the whole picture of the patient. You're not necessarily going to adjust something just because that level is 2.8. Vedolizumab, ideally around greater than 20 at 6 weeks during induction. Good news is these drugs have low immunogenicity. So factors that can affect pharmacokinetics with anti-TNF therapies. How does drug clearance increase? Well, if you're a male, higher BMI, high drug antibody, high TNF baseline concentration, low albumin, and high CRP. Those are all going to clear the drug quicker. We all know that they're going to need more drug in the beginning. So anytime you want to load up, you got to load up big time with those kind of patient populations, because otherwise they're going to clear it like that. Decrease in drug clearance, concomitant immunosuppressants. That's when we talk about adding that immunomodulator with your anti-TNF drug. That's putting your best foot forward so that they can achieve efficacy into remission. So where are we going forward now with positioning our drugs? Many times it's a little bit of roll of the dice. Like what should we pick? What are we going to do? I mean, sometimes we have an idea when we have like severe Crohn's or severe UC. We've mentioned infliximab in the hospital, but other times now we have so many choices. Where do we start? So now we're doing more research into predictive biomarkers. We're doing tissue sampling to look at genetic biomarkers, the microbial biomarkers, what's really kind of the root cause of where we're seeing these inflammatory cascades starting to take effect. And so I don't know if you're starting to see it at our institution, but we're definitely taking them to biorepositories to see if anything matches up. And that's where we're going to really have less of a guessing game in choosing these drugs going forward. And then finally, little bit on dual targeted therapies. Are we going to be able to match up biologics with maybe another biologic, a biologic with a small molecule medicine? There has been some data with an IL-23 and an anti-TNF. Those are duets. UC and Crohn's. And then vedolizumab with an anti-TNF and methotrexate in Explorer. So it's going to be a really fascinating time to see, now that we have all these drugs available, where we can go with them. This doesn't talk much about it, but we are going to start to see more trials with small molecules, and more specifically vedolizumab. I may be into the IL category. So more to come with that. But at the end of the day, it's a good thing that we have all these available. Don't be overwhelmed with the idea of you may get it wrong. Just keep it simple. Think about your disease severity. Think about what's going to be most effective for that patient. And then think about also the safety component. And then when that all comes into play, you got to take the human component in with that as well and see what works for them as far as their lifestyle goes. Oh, that's it.
Hello, everyone. Great presentations. My name is Norma Solis. I'm a nurse practitioner at the University of Miami. And this afternoon, you have heard great presentations from my colleagues about disease process, pathogenesis, pathophysiology of IBD. And I'm going to be switching gears now with IBD in healthcare maintenance. These are my disclosures. I have included valuable resources in IBD that focuses on areas where IBD patients are known to have increased risks. ACG clinical practice guidelines and the CCF professional education committee that you can read more at your own time. Healthcare maintenance in IBD is very crucial because patients with IBD have increased risk of a variety of health issues beyond the gastrointestinal tract. These include elevated risk for infections, osteoporosis, skin cancers, and other malignancies. As you have heard this afternoon, we have different medications and different modalities with different mechanisms of action that can increase risk factors and malignancies. And we're going to be discussing this in future slides. This is a summary of a list of recommendations for inactivated vaccines. We're going to be discussing in more detail in future slides, but I want to highlight the Tdap with all of our patients, hepatitis A and hepatitis B. I check titers for those. I usually don't see adolescents, but sometimes patients in the adult side are not vaccinated of the HPV, and usually I try to recommend those. And we're going to discuss influenza, meningitis, and streptococcal pneumonia in future slides. These are the summary of recommendations of live vaccines. I usually try for my patients to be vaccinated prior to initiation of biologic therapy or any other modalities of the current medications that we have for IBD patients. And we have to be very cognizant because after they start, it all depends on the patient, actually. It all depends on the severity of the disease. Sometimes I'm not able to wait for them to get vaccinated, and I would start the medications if the patient's merits. So the MMR we're going to be discussing, but it's contraindicated because it's a live attenuated vaccine. Varicella, we check titers for, and we're going to be checking the herpes zoster, which before it was patients of 50 years and older, but as of 2021, this changed and is 19 years and older that are immunosuppressed. So sometimes I do recommend those, as well as send a prescription to our local pharmacy that we're going to be discussing in later slides. So patients with IBD are at increased risk, as we discussed before, in contracted influenza, as often face severe outcomes. So we have to be very cognizant of this, and we have here an annual incidence of influenza and IBD versus their controls. And if you can see in UC and Crohn's disease, and you say, what is all IBD? Sometimes we have indeterminate colitis. So this is where we grouped our patients. And in all of the cases, you have increased risk of developing influenza and complications with pneumonia and as well as hospitalization. So influenza vaccine, I recommend my patients to have it yearly. Some patients don't, but we have to document very well that we are recommending these vaccinations, including the herpes zoster or any. So what I have is, and what I recommend for you to do is also have like a smart phrase of all of our healthcare maintenance vaccinations, and as well as dermatological evaluations that I'm going to be discussing in future slides. So pneumonia is a risk, a significant concern due to several factors related to the disease process, because not only that the patient has increased inflammatory response, as well as the medications that they are in. So we have to be cognizant of this, and we know where the immunosuppression and the medications that we have, and we're going to be discussing this. So chronic inflammation and autoimmune response, as well as extraintestinal manifestations. We don't realize that patients with extraintestinal manifestations of their pulmonary involvement, such as interstitial lung disease, can also predispose patients for pneumonia. This is a general algorithm of the pneumonia vaccines for adults older than 19 years of age. And because of time, I'm not going to go through each of them, but you can, it's in the CDC guidelines, and then you can research that at your time. So what is defining systemic immunosuppression? Gabby discussed that her patient was on 60 milligrams of prednisone. And we have here research that 20 milligrams of prednisone every day for 14 days, you're already immunosuppressed. So you can imagine her patient at 60 milligrams a day. Other immunosuppressants also that we used to, now with new mechanisms of action, we don't have to use immunomodulators, which is great, but you will be surprised that I still receive patients from the community on immunosuppressants. Cyclosporin and tacrolimus are still used in the hospital setting. You can see the biologic therapies as well that are immunosuppressant. You're not going to see vedolizumab because vedolizumab is targeted in the gut, so it's not considered immunosuppressed. But then you can see the rest of the biologic therapies and small molecules. So varicella vaccines in IBD is contraindicated because it's a live attenuated, right? Patients who are immunosuppressed therapy due to risk of disseminated varicella vaccines. So for the varicella, seroprotective status should be checked with varicella zoster virus IgG antibodies in all of our patients without documented vaccination record or exposure. If you are going to start the patient on immunosuppressive medications, all of the patients who are not immune, which I would recommend that, receive 2 doses of this series 4 to 8 weeks apart, 4 weeks before any immunosuppression medications that can be postponed. If we can't, then the patient cannot be vaccinated. The risk of shingles. As you can see, the risk of shingles are in patients that are immunosuppressed as well as the elderly. We have to take that in consideration as well. So they have their immune system depressed because of their age, as well as the medications they are in, and because of the inflammatory response. So if you can see, there is incident rates of herpes zoster in a JAK1 inhibitor, which is tofacitinib. But if you see that those are on higher doses, and as Gabby said, that are in the RA population, but you still have increased risk. Now we used to have the live attenuated vaccination, but now as of 2017, we have the recombinant vaccine, the Shingrix. So this is what my patients are mostly recommended. And the risk of the herpes zoster are considered combination or other immunosuppressive therapies. Especially when you are on combination therapy, you have to recommend this vaccination because they have increased risks. The MMR vaccine. So despite of universal MMR vaccination, you will be surprised that a lot of patients are not being vaccinated by the MMR, or they have lost their response. I recently had a patient who happens to be a doctor, and he used to be a fellow, and now he's coming back. So he went to employee health, and he had low titers of the MMR. So the provider in the employee health told him to stop the biologic therapy. So it was a very interesting because he said, I'm not going to stop my biologic therapy. I'm going to speak with my gastroenterologist, and you should not be recommending the patient to stop their medication to get the MMR. So we provided a letter for him to get that step, getting him employed. So the OIBD consensus is that every patient should be vaccinated for COVID-19. We have a lot of our patients who have a misconception of the vaccine, but we have to be adamant of stating that the key opinion leaders and experts do recommend them to be vaccinated and to have the vaccine. So cancer screening, mental health, and bone density. We're gonna go more into detail. We screen all of our patients for latent TB before initiating immunotherapy, or the insurance companies would not approve. So we use the IGRA quantiferon. Is preferred over the skin test because it's better specificity and less likelihood of false positives. I usually do get false positive quantiferon golds, and I usually try to repeat before I recommend a chest X-ray, or if I recommend for infectious disease. If it comes back positive again, I do recommend a chest X-ray as well as doing a infectious disease consult. Some of our patients, I live in South Florida, so a lot of my patients are coming from areas where they did receive their vaccine, and they sometimes are always positive. So I usually try to recommend patients to go to infectious disease, get that under control if they have not, and then we can start the medication. Osteoporosis. This is a meta-analysis that showed that 38% of absolute increased fracture risk in IBD compared to their controls. So this is very important for us. Sometimes we don't realize, specifically women that are in menopause, they have increased risk. So we try to do the DEXA scan, and these patients who have normal initiation DEXA scan assessment should undergo repeat in every 5 years. Some patients that do go through menopause independently of their IBD, and they have osteopenia, osteoporosis, they can receive their medications without any interaction with their current inflammatory bowel disease treatments. So sometimes I ask patients to go to their PCP or go to rheumatology for them to have a better outcome in terms of getting their osteoporosis under control. So this is a very hard depression and anxiety for us, because sometimes in our rush every day, we don't ask. And sometimes you will be surprised of the patients when we do ask and they respond that they are having anxieties and depression. So it's very important that us as providers, and specifically the population in IBD, we ask for depression and anxiety. Studies suggest that 30 to 40% of patients with IBD experience depression, and up to 20 to 35% of patients experience anxiety. Rates do usually go higher when the patients are having flares or they have chronic severe symptoms. Screening tools. Right now, we have incorporated these screening tools of depression and anxiety in our electronic medical records. Usually by the time they get to me, they have the conversation with the nurse of the MA, and they usually alert me if the patient is having any types of symptoms. We are lucky enough at the University of Miami that we have a social worker that works with us, that I could refer these patients to have cognitive therapy, as well as mindfulness-based stress reduction therapies. So it's very important to those that are in the community and you don't have a social worker or a therapist available, then the recommendation and referral is warranted. Colorectal cancer screening in IBD. As we know that patients that have 8 to 10 years of disease progression or disease process should be screened for colorectal cancer. Actually, we had a patient and we were having a conversation earlier with my colleagues. When is that you choose to screen for colon cancer? I know that there's different guidelines. They're saying that 2 to 3 years, 1 to 3. So it can be very confusing. But we usually try every year if patients have PSC, and other patients, if they are stable and in remission, we usually go to 18 months or 2 years. It all depends. But I recently had a patient that had good colonoscopy and a year after had dysplasia. You see here and all my colleagues that said, oh, no dysplasia or granulomas. So what does that mean, right? So dysplasia can be very serious, depending if it's low-grade dysplasia or high-grade dysplasia. And so it can be very scary for the patients as well as providers when you read that pathology and you say, wow, last year that patient was well, and then a year later has low-grade dysplasia. Now we have to discuss with the patient about colectomy, and that can be very concerning for the patients and the family members. So here is the colorectal cancer screening in IBD. So we have patients with extensive colitis. 1/3 of the patients of colon involvement, more than 8 years, should undergo surveillance colonoscopy every 1 to 3 years, depending on the cancer risk. We have to understand if the patient had a colorectal cancer in their family, we know that we need to screen a little bit more and be very conscientious about it, as well as the patient having PSC. Cervical cancer. I had a patient that was on an immunomodulator many years ago, and she developed high-grade dysplasia of the cervical on her cervix. So we had to discontinue the immunosuppressant, and she underwent, we changed to a less immunosuppressive medication, and she was being treated for it. So it's very important that all women with IBD who are treated with systemic immunosuppression undergo cervical cancer screening by cytology annually. Skin cancer risk in IBD. We are talking about the non-melanoma, are well-recognized complication of immunosuppression. I usually try it at for new patients. I usually ask, were you in immunosuppressant in the past? Because we have seen several years after the fact that they have stopped immunosuppression, and now they have non-melanoma cancers. So it's very important that they get an annual dermatological evaluations. So you have heard about protective, non-protective of smoking, right? So smoking in Crohn's disease is associated with the worst prognosis. And also it increases the risk of onset and exacerbation of flares. So what we have to understand is that this is very hard for them to stop smoking. So we have to leverage those individuals little by little. So are you ready to stop smoking? We can refer you to a smoking cessation program. But sometimes they say, Norma, I'm not ready to stop smoking. So we have to give them some time, but give them also the education and give them the information that their medication might have low threshold because of their smoking. And all of the sudden you say, I get a call from the patient saying, Norma, I'm ready. So please refer me to the smoking cessation. And in an academic institution, we do have those programs available. Smoking in UC has a paradoxical effect, right? It's more protective, specifically in the mild disease. So the patient says, oh, so that means that I could continue smoking. And I usually say, no, that's not what I meant. But So, so it supposedly said that nicotine components of cigarettes has been proposed as factor contributing to its anti-inflammatory properties. So despite the protective effects of smoking, is still, a situation where we need to refer them to the smoking cessation. So this is a list of the monitoring for the conventional therapies, and we have mesalamines. Actually, we had a discussion yesterday where we say to the patients, mesalamines are safe. You don't have no side effects. And in actuality, they do. And we have to usually check the renal function. So it's very important for us to do so. If they do, then we have to discontinue the mesalamine and we have to advance the therapy. We have methotrexate, thiopurine, and corticosteroids. And you have the list of the monitoring. So in my next slide, it's so important. How are we doing as providers? Who's responsible for it? And we're going to be discussing this. So we're not having a good outcome in preventive care in patients with IBD. So 48% of gastroenterologists do not ask their IBD patients about immunosuppression because of timing. I usually try for patients to come in or do a quick telemedicine visit just to go over their healthcare maintenance. And I try, I wasn't aware that I should be, doing a dermatological evaluation. I wasn't aware that I needed to do, the vaccination. So it's very important about educating and trying to give the patients the best information as possible. So 28.7% of patients do not get vaccinated for influenza, and 16.5% of patients do not get vaccinated for the pneumococcal. So it's very important. 23% of eligible UC patients screen for low BMD according to the AGA guidelines, and 13.5% lower osteoporosis screening rate for IBD patients compared to their non-IBD controls. So we have to do a better job. There was a study that said that adolescents have less frequent health maintenance examination than their peers. I usually try for those patients that I see that they're not compliant, I try to get their parents involved. And I think when I get their parents involved, they usually get their vaccinations in order. But it's very, very important that we put the patients accountable for trying to get these medications and trying to get the healthcare maintenance current. So whose responsibility is it? Is it the gastroenterologist? Is it the PCP? So we have managed IBD-related maintenance issues, and who's responsible? And if you can see in both, gastroenterologists should manage IBD-related healthcare maintenance, or should the PCP? So we have conflicting answers. It should be the gastroenterologist, but I believe that it should be a multidisciplinary team approach. The same way that you usually refer patients when they have extraintestinal manifestation to rheumatology or dermatology, should be the same thing with patients with to their PCP. I was discussing earlier that I had a patient that used to say to me, Norma, you're my PCP. No, well, no. I love you, but I need for you to be seen by your primary care. He took a while to understand this, but then he was diagnosed with thyroid cancer, something that we do not focus on. As well as for males, the PCA, we don't focus on these things that should be focused more with the PCP. So I think working together is for more patients, a better patient outcome. So leveraging with local pharmacies. I usually work with my local Walgreens and CVS for patients to receive their vaccinations. Some healthcare insurance companies do not approve, so they will approve it at their PCP, or only they have to pay their copays to see their PCP and they can get the vaccination. But some insurance companies do not approve the vaccinations to be given by a hospital-based facility. So I usually try to recommend to their local pharmacy and work together with them in order for them to get their vaccinations current. So it's very important, specifically their annual influenza. Even our Publix, I don't know if there's a supermarket, they have a pharmacy in their local drugstore. So I usually try to send them there in order for them to be fast. They don't have to wait long lines. So work together with your local pharmacy. So how would you keep track? Now we have our phones. Our phones, we cannot live with our phones. We have different apps that can also use as tools to track healthcare maintenance. So these are the healthcare maintenance tools that we used to work with, and I usually still work with the CCFA as well as the Cornerstone. When I first started, and I'm not gonna tell you my age when I started IBD, but when I first started, I used to love the Cornerstones, and I still have some of my nurse practitioners use the forms in order for them to become more aware of what we need to check specifically with their IBD and immunosuppressions. So in summary, despite unique health maintenance needs, preventive care in patients with inflammatory bowel disease remains suboptimal. So we need to make a better job. Health maintenance gaps are particularly notable among certain populations, including the adolescent and minority populations. Vaccinations are important strategies in reducing the risk of disease and treatment related to complications. And gastroenterology providers are encouraged to work with their primary care clinicians to facilitate the use of current screening and vaccination recommendations for patients with IBD. Thank you.
We're going to open up to Q&A. I'm going to invite all the speakers, if you don't mind coming up. Thank you again to everybody. I think you all will agree, a lot of amazing information in a very short period of time. If anybody has any questions, if you're loud enough, feel free to raise hand. I'll call on you from your seat. There are microphones placed in the aisles as well. Yes, go ahead. Sure. Yes. Great question.
No symptoms.
They can come to the phone.
Okay, so first question, I'm going to throw it out to whoever wants to be eager on this one, because I think a few of you touched on it. Allison, I think you may have done more, but don't correct me if I'm wrong. So the question was kind of, how do you decide with steroids whether you're going to go to a budesonide kind of, more first metabolized versus a prednisone?
Right. Is this on? Okay,
Yeah.
great. So first I want to make sure that they don't have an active infection before I start any sort of steroid. And then sort of going a little deeper is, have they been on prednisone or budesonide before? Which one have they responded to? And then if it's more of a mild to moderate case, I'm starting budesonide, either oral, rectal, both, seeing how they respond. And if they're not really having the response I want them to, we can escalate to prednisone.
Awesome. So the second question, same attendee, great question. What do you do when that fecal calpro is still high, but patient doesn't have symptoms? Is that the question? Okay. So kind of that subjective versus objective. I don't know who wants to tackle that one first. All right, Erin, you look like you're ready.
I think it's a good biomarker to utilize, but if you're seeing, it just depends. If that's the first time you did a calpro, are you trending a calpro? Is it moving in the right direction, for one? Two, if not, and they're feeling well, then I usually will then refer to getting them scoped to see really what's going on under the hood, right? Like, so you can only use a number for so much, but then you got to get an idea of how severe the disease is, how aggressive we need to treat it. You just need a little more of an answer. Because sometimes it's not always there with the CalPro. That would be what I do.
What I'll usually do too is if they're feeling well, I know they're in remission, kind of get their baseline calprotectin to see where they stand. If a patient has like pseudopolyps or anastomosis with an ulcer, sometimes their calprotectin is going to be a little higher than sort of that, less than 50 or under 120. And then if it's not coming down, you're starting to say like, okay, should I scope and actually see what's going on the inside?
Go ahead.
Hello. If you have a female over 50, she has UC, pancolitis, has been on mesalamine and 6-MP for quite some time, has done well, endoscopic remission. Question is, when do you start talking about stopping that 6-MP? As she's getting older, risk increases.
Now, I believe that we have different mechanisms of action that are safer than just having the patient on 6-MP. So I would probably get a colonoscopy to just confirm that they are in remission and have that conversation that we should switch, because I just recently spoke about the developing of known melanoma cancers in patients with immunosuppression.
So you do switch to something else. You don't leave them hanging just on mesalamine.
No, I would switch them.
Multiple years, over 5 years in remission.
Over 5 years in remission. I would change that 6-MP.
Anyone else want to add?
I think it's a risk benefit discussion. I mean, so I have lots of patients who just are adamant about staying on their immunomodulator, and you just have to let them know that there's a risk of non-melanoma skin cancers that's going to progress as you get older, right? Because then you've got more time in the sun on your skin, and then the cervical cancer risks, right? So they're going to need to be screened yearly for that still going forward. Are you okay with that risk? Let me tell you, there's other therapies available, but really it's likely the 6-MP is keeping her in remission over the mesalamine. So there's a potential that they will flare if you try to pull the 6-MP and not replace it with something.
Currently, it's about 50% that the patients will flare. So it's a risk benefit.
There's also just the potential, if you have a patient who is willing to go off of their immunomodulator, but doesn't feel comfortable at this point with biologics, is just really closely monitoring them, seeing them every 3 to 4 months, getting fecal calpros and monitoring. So you'll recognize if there's a trend upward with their inflammation, and then they may feel more comfortable than having that discussion about transitioning to a biologic or small molecule as appropriate.
There were also some studies done, and I can't quote which ones, but above the age of like 63, really 63, 65 to really start discussing with your patients getting off the immunomodulators.
Go ahead.
So typical dosing is 5 milligrams per kilogram, but because of the symptoms he was having at the time and how miserable he was, and that was one of the worst looking colons that we have ever seen. That's why we chose that higher dose, and we put him on the azathioprine to decrease the immunogenicity of, to not develop drug antibody. And we kept him on the azathioprine for 1 year. And he's been good. His drug levels have been good. And again, we did have that discussion about, do we decrease this? I had the discussion with the physician as well as the patient, and decided to keep him as is, see what it is. His 3-year follow-up colon is next year. So we'll have that discussion again. Yeah.
That's a perfect example of drug clearance as well. So when that patient has severe disease, they are going to burn through that drug super quick. So the best example I can give is like a hose to the fire, right? If you only give a little bit of water, the fire is going to get bigger. But if you put a lot more water on it, it's going to go out. So you just got to go aggressive initially with that kind of severity to get it better under control. So hiring the dosing and being aggressive is actually the ideal thing to do when they're first sick.
Just to piggyback on that, if you're checking their labs, as I know you are before you start them, if they have a low albumin, if they have some of these other factors, there's data to back it up if you're getting barriers to coverage for a higher dose for initiation.
Do you get cross-sectional imaging to evaluate the small bowel in all of your Crohn's patients? And if not, when would you do it?
Sure. I mean, I think that so you're talking about like CTE, MRE. It's a definitely a good modality to use, sometimes in combination with endoscopy, so that we can see the small bowel as was talked about, or also sometimes, if we don't want to do a scope every single year, that's another way to follow. So your question was, do you do it? I think everybody does. And then was it when?
Do you do it on all of your patients as
All Crohn's patients? What's kind of that giveaway for
all
when
Crohn's
you do
patients?
small bowel evaluation?
I mean, at some point, the small bowel needs to be looked at in all patients. If it's somebody, please tell me if anyone disagrees, but if part of the diagnostics, yeah, if it's somebody, and then periodically, right? Like if there's someone who's never had small bowel disease, it's not that they couldn't develop that over time. So depending on symptoms and progression of their disease.
So I think it's individualized. If I have a patient that you have jejunal disease and it's more proximal than the terminal ileum, then I usually do more MREs than colonoscopies because I'm not going to see the disease. Then the other component is if the patient is on maximum dose of the medication and still having symptoms, I want to look for structuring disease. So I would do the MRE, and specifically on patients that are perianal disease, I usually do it often.
Go ahead. Norma, you want to?
So it all depends on the history of the patient. If they had any cervical dysplasia, then obviously we have to work with their gynecologist to do it more often. I think every 6 months to a year, but it also depends and it's very individualized. But the recommendations are there that they should be doing annually. On the geriatric patients, I think it's a little bit more leverage, but they have to do that recommendation depending on the patient and their history.
Yeah, go ahead. Okay, so question was kind of in what way do you use the IBD panels? So whether it's ASCA, ANCA, Prometheus panels, if you see an ileitis, you're not really sure, kind of what's your guidance on your clinical practice of when you would put these tests into practice?
We certainly still order IBD markers. That patient did not have any granulomas on the pathology, so typically you would see that. But certainly, if you're not sure, that just provides, and the IBD markers do provide another, another.
Yep, another indicator.
No,
So
another
I'll
marker,
have,
yeah.
I'm curious to see what others have to
Data
say. I will
point.
share. I think I use them less and less now.
Mhm.
I think the more we've learned about the differences of Crohn and UC, even if with colonoscopy, we don't really have an answer. I think that's sometimes where the imaging and or other kind of markers will help us. So for example, if they have pancolitis and it's backwash ileitis, it's pretty easy now to distinguish from those typical like skipped areas that we're going to see more often in Crohn's. So I personally don't use them that often anymore, just because I think we're able to tell. I think the one important thing to remember is they're not very high in sensitivity specificity. So we see a big overlap that yes, ask us Crohn's, you can still see it positive in UC patients and vice versa. So I think you just have to think about the yield if it's really going to change what you're doing.
I was just going to say, is it going to change your treatment protocol? Majority of our, you're treating their symptoms and you're treating their underlying inflammation, other than potentially using an Entacort over a budesonide extended release, to target that area. But most of our advanced therapies, they're all indicated for both diseases mostly. So is it worth the cost of the test? Because is it going to change what you're going to do? And does I think that just kind of comes down to how you're going to utilize the results.
We use it less and less, as Kim was indicating, but just for mood educational point for the fellows. But in reality, as Jamie was indicating, most of our medical treatments currently are for both indications. So we usually don't use it much. We usually screen the patients because I'm a tertiary referral center at the University of Miami. So by the time they get to me, they have been on years of prednisone as well as other biologic therapies or immunosuppression. So we usually.
Yep. So I think it's a great question. So in general, and if anybody else wants to speak to this, usually what we look at is if that patient has a risk factor of having been cumulatively over time on steroids for at least 3 months, that in general is, in my experience, when I start to consider at least a baseline screening.
And you want to get that as baseline as well, even though they don't
even
have
those 20-year-olds, if they've been on steroids and it's added up to that period of time, you should start screening. Yeah, go ahead, please.
To the when you would get an EGD on these patients. So somebody had mentioned if they're having symptoms, but most of the time our IBD patients come in with diarrhea. But then you might have the patient that's like, well, I have a lot of nausea or, non-specific upper GI symptoms. So when would you order that testing?
If a patient has upper GI symptoms and nausea, I'm going to scope them. I go in 2 times. So if you're doing the colonoscopy, might as well do the upper endoscopy. If they have an anemia, we're going to want to have a look. Peds often, they do the whole gamut. So they're coming in with sometimes even a baseline upper endoscopy. And if it wasn't seen at diagnosis, a little less so. But I'm pretty quick to trigger on doing the upper endoscopy as a just in case. I'm not sure how others
agree.
Mm-hmm. And by having esophageal or gastric Crohn's disease, we can determine that the disease is very aggressive, and that's how we have to treat this patient. So we do baseline EGDs even if we're having upper GI symptoms.
Danica.
Regarding vaccination, let's say you've had a patient maybe on a TNF or something for a while and nobody ever bothered to risk stratify for MMR, or maybe even some of the more live vaccines when you're thinking about on the back end vaccinating them. When do you go chase those down, even if you know that we don't necessarily want to pause their Remicade and do some sort of live vaccine if their titers are low or something like that?
I wouldn't stop their medication. I would just leave them as is, to be honest with you, because the risk of patients flaring, it's greater than them getting the mumps and rubella. I wouldn't.
No.
I also try to bring that up really early in their disease. So even though we're not thinking about advanced therapies yet, I try to get all my baseline testing, and not everybody is up to date on their vaccinations, as we know. So
for the patients who have an acute flare and they're in an inpatient setting, whenever ID gets involved, they always start them on PJP prophylaxis. Once they're transitioned to the outpatient setting, is that something that you would typically take off while they continue to taper their prednisone, or would you leave them on it? And do you tend to put people on Bactrim yourself if they're being on a prolonged prednisone taper in the outpatient setting.
Will you just clarify that? So you're saying ID starts them all on Bactrim for prophylaxis regardless of their risk of...
Yeah, so if they're on methylpred, or at least this happens at Yale, if they're on methylpred or if they're on greater than 20 mgs of prednisone, we have like a standard, they end up going on PJP prophylaxis until they're off the prednisone.
I typically do if they're triply immunosuppressed. So if they have an immune modulator, TNF, and then pred, we're doing that. And then usually once they're off the pred, I'm taking them off the Bactrim.
Erin, do you want to add something? Okay.
I will taper them once they get below 20. Okay.
Based, would you kind of refer them up?
Erin, go for it. You look ready.
Get surgery always involved right away with fistulizing disease because medicine alone, the literature does not show that it's going to be phenomenal in healing. I think with infliximab, it's at the most 30%. Less than that maybe. So the minute you see fistulizing disease, it is a communication with surgery and you to do both right away. And combination therapy.
You want to keep those drug levels very high in perianal or fistulizing disease, and then also making sure there's no infection either, because the infliximab's not going to work if there's an infection or in helping healing.
They'll do better from a surgical perspective if you better manage the underlying Crohn's disease. So getting them into a more endoscopic remission, seeing how that fistula responds to it, and then, I mean, surgery should be involved even when they're active, but they'll usually favor intervening once they're in remission.
All right, we're down to the last minute. If there's any final questions. All right.